Cardiovascular alterations part 2. Again, these are all fusiform aneurysms. In other words, they involve all three layers of the vessel wall. The A is of the ascending aorta. B is of the aortic arch that involves the brachiocephalic, carotid, and subclavian arteries. And C is of the descending portion of the aortic arch. This is still up in the thorax, and that, I believe, is where John Ritter's was located when it ruptured. The D is a large fusiform part of the thorax and abdominal aneurysm that involves the celiac, superior mesenteric, and your renal arteries. So if that would rupture, it would cause a major problem. The E is of the abdominal aorta and the iliac arteries. F is of the femoral artery, and G is of the popliteal artery. And remember, we talked about Marfan syndrome under genetics, where they would have multiple aneurysms. And again, this is just showing some of the locations that they might have for an aneurysm location. A dissecting aneurysm, remember, was when two layers of the artery would divide. And if you look closely, you can see that you have a division right here. We don't want to do that anyway. That shows right there the split in the arterial wall. So you have a true lumen and a false lumen in the aortic dissection. And that's the intimal flap that separates the two. And this again is showing the aortic dissection with color slides showing the color flow during ventricular systole that suggests the upper lumen is probably the true one, where the lower one, where there's just a little bit of color, is probably the false one. Peripheral arterial disease is an example is thromboangiitis obliterans. And thromboangiitis obliterans is also called Berger's disease. This is an inflammatory disease of your peripheral arteries with thrombus formation and possibly spasms that occur in that extremity. It affects your hands and your feet. Symptoms are due to a decrease in blood flow, which will cause pain and tenderness. The dilated capillaries will cause rubor, or the redness of the skin that occurs, and the warmth that's there. Chronic ischemia will lead to a thin, shiny skin and malformed, thick nails. Acute ischemia can actually cause gangrene. This tends to affect young men who smoke cigarettes. I took care of a 21-year-old man who was having his left foot amputated for this problem, and he continued to smoke. In fact, the day of surgery, he said he really needed a cigarette before he went to surgery to have his foot removed. We all know that cigarette smoking has nicotine in it, which can cause vasoconstriction, and it also increases the heart rate, so it increases peripheral vascular resistance, and that's why this occurs. Took care of another gentleman who was coming in and was having his fifth surgery, and this one was for disarticulation of his right leg. In other words, they were removing the leg at the hip because it caused necrosis. This man had had 2 prior MIs and did have COPD and was continuing to smoke. He'd already lost his entire left leg. So this was to remove the rest of what was left of his right leg. Sad. Raynaud's disease is when you have spasms of your small arteries and the arterioles in your fingers and toes. This is due to ischemia and vasospasm. You'll have changes in color, pallor, numbness, and your digits, your fingers and toes will be very cold. There are different types. The phenomenon is secondary to a systemic disease such as scleroderma or pulmonary hypertension, or could be due to prolonged environmental exposure to cold and vibrating machines. People who work with construction on the highways, and they break up the cement and stuff, but those vibrating machines can cause it. If it's the disease, Raynaud's disease, it is due to possibly a genetic component. But it is triggered by cold and stress. If you're in a warm, stress-free environment, you don't have any problems. When you're in the cold or under stress. Alterations in perfusion can also occur, and usually, this is going backwards, I don't know why it's showing in here backwards, but anyway, atherosclerosis is when you have the soft deposits of intra-arterial fat and fibrin, which narrow the lumen over time. Atherosclerosis, that is where the tunica intima, which is the inner layer of the arterial wall, thickens, stiffens, and narrows due to infiltration of the smooth muscle by cholesterol. And it involves the process of atherogenesis. And atherogenesis, if you break it down, athero means fat and genesis means growth. So it's the growth of fatty tissue. Now, we all have, like under the age of 1, they have found the fatty streak. So it's been found in the aorta of children under the age of 1. It is a flat, lipid-filled smooth muscle cell. So it does not cause any obstruction. And it actually is a collection of macrophages with cholesterol as their cytoplasm. These are foam cells. So over time, fibrous plaques will develop from that fatty streak. And the core of that fibrous plaque will contain debris from necrosis because that area doesn't get a good blood supply. And there are lots of lipids there. And then that lesion will protrude into the inner layer of that vessel wall, into the intima, and it will invade the media, or the middle, of the blood vessel. Here's a picture showing a normal cross-section of a coronary artery. This is showing the yellowish atherosclerotic plaques that can be in the blood vessel wall. Now here, the left lumen, the vessel on the left, is about 50% occluded. At the right, there's been thrombosis with organization and recanalization. In other words, there's still some open, to leave 3 small remaining open lumens. And you can see, here's one, and here's one. A complicated lesion is when you have plaque that's altered by hemorrhage, calcification, which tends to occur the longer it lasts, cellular necrosis, or a mural thrombus. It's also often called an advanced lesion. And here's hemorrhage into an arterial plaque. You can see that now. This is done on post-op, so that's why the tissue around it doesn't look very healthy. There are different theories of atherogenesis or how this occurs. It could be reaction to injury from hemodynamic forces, such as hypertension, or from harmful chemicals such as nicotine in cigarettes, and catecholamines, again from hypertension, or from bacterial infection. They're trying to implicate H. pylori again as a possibility, and also your strep and staph as possibilities. Hyperlipidemia from your high lipid levels, high cholesterol, or trauma to the blood vessels, tight jeans, constrictions, that sort of thing. Lipogenic theory says that you have a high level of your low-density lipoproteins and a low level of your high-density lipoproteins. Now remember, your high-density lipoproteins are considered protective because they attach onto cholesterol and take it to the liver for it to be used appropriately, rather than allowing the cholesterol to line the arterial walls, which when you smoke is what it does more often than not. Clonal sentience is another theory, and this says that as we age, that allows for an increase in the growth of smooth muscle cells and lipids. The thrombogenic theory says that we have microthrombi, little tiny blood clots that accumulate on the endothelium or the inner lining of the blood vessel walls, and they then release a factor which stimulates smooth muscle growth in the blood vessel, so that narrows the lumen, making it harder for the blood to pump through. And lipid infiltrate is when lipids accumulate around the smooth muscle, narrowing the lumen. And all of this can lead to peripheral arterial disease, which is atherosclerosis of your peripheral arteries. This tends to occur particularly in diabetics because, remember, diabetes is a disease of metabolism. And this is your metabolism is not effective. So your cholesterol levels tend to be elevated. It can be very gradual, or it can occur as an acute episode. You'll have pain with ambulation. So when you walk around, yeah, it hurts. This is called intermittent claudication because when you stop walking, the pain goes away. That's why it's intermittent and contraction. Patient is asymptomatic, but there will be a bruit. In other words, when you listen to the blood vessel, you will hear turbulent blood flow, which is what a bruit is. It sounds like a murmur in a blood vessel. It's a sound, and I don't know if I can translate it, but it's a blowing sound. It can lead to a complete occlusion. Coronary artery disease is one of the major causes of death, cardiovascular disease. Look at it as being on a continuum, where it starts with coronary artery disease, then leads to ischemia, and then leads to infarction. These disorders are all now grouped together as acute coronary syndrome. Back in the dark ages, when I first started nursing practice, we used to admit patients with the diagnosis of chest pain. Chest pain is a symptom. It's not a disease. And as a symptom, insurance companies did not reimburse it very highly. And there are a lot of tests that need to be done to diagnose the etiology of this symptom. So medicine got together and decided to change the diagnosis to acute coronary syndrome to address that issue. And now that involves everything, including a heart attack. Everything from chest pain to a heart attack. Coronary artery disease is when you have a decreased pumping ability of the heart due to decreased oxygen and nutrients there in the heart. There's always some degree of blockage, but you don't have any symptoms until the vessel is at least 50% blocked. And usually by the time the patient's complaining of chest pain, it's about 90% blocked. And there are multiple risk factors for coronary heart disease and atherosclerosis, some that are totally non-modifiable. It can't change your age. It can't change your sex, and men still have a greater risk factor as far as coronary artery disease is concerned up to the age of about 45 or 50, when women start to equalize. Now that changes if they take birth control pills and or smoke. Their risk factor gets a little bit closer to that of men younger. But it can't change your sex. Even if you have the sex surgery, you're stuck with what you were born with. So if you were a guy who's now a gal, you still have the risk factors of being a guy. Your family history is also something you cannot change. But that usually is not a concern unless your family had their heart attacks before the age of 70. Risk factors that are modifiable are things that you can affect that don't go away, but you can change. For example, dyslipidemia, which is an abnormal concentration of your lipoproteins due to genetic and environmental factors such as diabetes, hypothyroidism, pancreatitis, renal nephrosis. This will elevate your low-density lipoproteins and lower your HDL, or your high-density lipoproteins, which we've already talked of as being the good cholesterol, because they pick up the cholesterol and transport it to the liver. And HDL also helps with endothelial repair and decreases thrombosis. Triglycerides also increase coronary artery disease risk because they are a precursor for cholesterol. And lipoprotein A is increased in women, and lipoprotein A increases cholesterol. Hypertension increases the risk 2 to 3 times because it contributes to endothelial injury, or the inner lining vessel wall injury of your blood vessels. And it also causes myocardial hypertrophy with an increase in oxygen demand, so it makes the heart work harder for less money. Not a lot of fun. Cigarette smoking. Nicotine increases catecholamine release, so it increases your heart rate and your blood pressure. It also decreases your HDL and increases your LDL. causes vessel inflammation and thrombosis. I might have mentioned earlier, smoking is bad for you. You might want to consider stopping if you do. Diabetes also causes endothelial damage. It increases the inflammatory reaction and thrombosis. It decreases the amount of nitrous oxide that's available, and nitrous oxide is a vasodilator. And it increases dyslipidemia because it's a problem with metabolism. And it leads to insulin resistance. Abdominal obesity also increases insulin resistance. It decreases your HDL, causes hypertension, decreased adiponectin, which is a protective protein for the heart. So obesity makes a difference. A sedentary lifestyle, you don't lose weight with a sedentary lifestyle, you just kind of sit around, or a diet high in fats, which is fairly self-explanatory. Non-traditional risk factors are your markers of inflammation, your C-reactive protein, and your eosinophil sedimentation rate, or ESR, because inflammation is very definitely indicated as a precursor to heart attack and or stroke. So if your non-traditional markers, your C-reactive protein and your SED rate are elevated, it tells you that you're at greater risk for a heart attack. If your homocysteine levels are high, because homocysteine increases inflammation, so hyperhomocystinemia, because that will lower your folate and your vitamin B12 levels. So you need to eat more folate and B12. Your green leafy vegetables, those are good for you. Infection, particularly with chlamydia and helicobacter, have been implicated in an increase in atherogenesis, as I mentioned earlier. And this is showing LDL. You'll want it low, below 130, or it will lower you into the ground. It will cause coronary artery disease. HDL you want high, above 40 if you're a male, above 45 I think if you're male, 50 if you're female. This is a little bit low, but you want it definitely above 35. Myocardial ischemia is when you have coronary artery disease with more than a 50% blockage. One cause might be atherosclerosis, which we've talked about already. Another cause could be thrombus that results from ulceration of that plaque and release of prostaglandin thromboxane A2. Now, prostaglandin thromboxane A2 causes vasoconstriction and spasm of the blood vessel. Prostaglandins always cause constriction in vessels other than the kidney. In the kidney, it tends to vasodilate those arteries, but that's a different kind of prostaglandin. The decrease in blood supply could be due to hypotension, decreased venous return, decreased blood volume, tachycardia, because the tachycardia itself will decrease the filling time. Not allowing that ventricle to fill enough will decrease cardiac output. If you have an incompetent valve, a valve that doesn't close properly, or a decreased amount of hemoglobin, because then you don't have enough oxygen available to transport, or if there's a decrease in the oxygen that's available in the air around you, say you're up at the top of Pikes Peak, or if you don't have enough iron, all of that will affect your ability of the heart muscle to get the oxygen it needs. If there's an increased demand, such as if you have systolic hypertension, or an increase in ventricular volume, increased thickness of that myocardial tissue, tachycardia, increased contractility, increased thickness of the blood or viscosity of the blood, anemia, hyperthyroidism or pregnancy, all have an increased demand for oxygen. And tachycardia can be caused by stress, exercise, anemia, an increased thickness of that blood or viscosity of the blood, and hyperthyroidism. So anytime you have demand that's more than the supply, pardon me, you have ischemia. And ischemia within 10 seconds occurs within 10 seconds of the occlusion. After 2 to 3 minutes, you have decreased contractility, decreased oxygen available, decreased glucose available, and it will cause lactic acidosis. Cell death will occur after about 20 minutes of ischemia. And the patient may not actually be experiencing chest pain until then. It depends upon the degree, the size of the area, and the degree of the occlusion. Keep in mind the Krebs cycle. Remember back in chemistry when you did the Krebs cycle, or anatomy and physiology. In the presence of oxygen, you get 6 ATP that are formed. In the absence of oxygen, you only get 2 ATP, and then you go into lactic acidosis. Now, would you really like it if you were told that you had to work 3 times harder than you were for a third of the money? I don't think so. And the heart's just as bad. Doesn't like it either. This is showing somebody who has myocardial ischemia. And hopefully the slides won't keep flipping forward as I try to use this little pointer. Anyway, you start with ischemia that decreases my oxygen supply, which increases cellular hypoxia, then alters the cellular membrane, decreasing contractility, decreasing cardiac output, decreasing arterial pressure, stimulating your baroreceptors, causing a sympathetic response that leads to an increase in myocardial contractility and peripheral vasoconstriction. Well, that peripheral vasoconstriction increases afterload, and that increase in myocardial contractility and everything that preceded it increases your heart rate, which decreases your diastolic filling, which decreases the coronary perfusion, so the heart muscle isn't getting all the oxygen it's supposed to. And it increases myocardial oxygen demand that makes the myocardial ischemia worse. So it just becomes a continuous circle that gets worse and worse unless it's interrupted somewhere. We talked about the heart rate and how the heart rate is affected. So let's look at changes of the EKG that occurs with ischemia. Normally, if somebody has myocardial ischemia, what you will notice is that the T wave will invert. That's here in the middle. It's showing T wave inversion. Sorry. When you have injury, you'll have ST segment elevation. Now, it depends upon the lead you're in. You may also have ST segment depression. But you always have T wave inversion first, then ST segment elevation over the area of the injury. The ST segment depression occurs over the area on the opposite side. It's called a reciprocal change. There are different types of ischemia. Angina or angina, both are correct. I was taught by a German, so therefore it's angina. Angina is chest pain that's due to ischemia and an increase in lactic acidosis. The pain tends to be transient, lasting about 3 to 5 minutes. Very similar to heavy pressure. It can radiate to the back, the arm, and the substernal area and or the jaw, and it can be characterized as indigestion. But it's due to the ischemia and the increase in lactic acidosis. So when you look at your patient, they'll be pale, diaphoretic, having some trouble breathing, and complaining of this pain. There are different types of angina. Stable angina is most often due to atherosclerosis. This is when pain occurs with or after exertion or stress. Unstable angina is unpredictable. You don't know what causes it necessarily, but or when it's going to happen. You don't know when it's going to happen. You could be sitting in a chair watching TV. You could be walking down the street. You don't know when it's going to occur. It's unpredictable. But it indicates advanced disease. Now, the onset and the course will differ each time, but nitrates will help both stable and unstable angina, as due to atherosclerosis and vasospasm. Prince-metal angina or variant angina occurs with or without atherosclerosis. It's considered usually due to a vasospasm, oftentimes by a calcium influx into that arterial smooth muscle, or an increase in activity of the sympathetic nervous system, or impaired production and release of your prostaglandin and thromboxane too. It usually occurs during REM sleep, and nitrates don't usually work well. So if you wake up suddenly in the middle of the night, it's probably Prince-metal angina. rather than unstable angina, if your nitrates don't work. Silent ischemia is asymptomatic. It tends to occur more in females. Oftentimes they'll just say that they're tired or maybe a little short of breath, or they just don't feel right. You can also have mental stress-induced ischemia. Usually this occurs if you have at least 75% narrowing of the coronary artery. Now this is a cartoon that we saw that was in the Sunday paper several years ago. Shows Ditto from High and Lois waking Dad up, who's sleeping on the bed. He goes, "Dad!" And Mom says, "Ditto, if you keep doing that, your father's going to have a coronary. Like when they make you king." So that's a good thing. You need to make sure your patients understand what you're talking about. I took care of a young man. He was 44, who'd had his heart attack. And I was waiting for the doctor to tell him he'd had a heart attack so I could start with the cardiac rehab stuff, because that's what I was doing at that time. And I wasn't able to make rounds with the doctor. It took me a while, so I had to go back in to see the patient after the doctor had been there. And I asked the patient what the doctor had said. And he said, "I feel so much better." And I thought, "Oops, that's not the usual response to being told you had a heart attack." And he said, "Oh, I feel so much better." He said, "I thought I had had a heart attack." And I said, "What did the doctor tell you?" He said I had something called a myocardial infraction. I said, "Infarction?" And he said, "Yes." I said, "Okay, good news, bad news." Good news, I'll tell you after I tell you the bad news. Bad news is, myocardial infarction is a heart attack. Good news is, doesn't mean you have to put your feet up in a chair and not do anything anymore. But a myocardial infarction is irreversible hypoxia and cellular death due to prolonged decrease in blood flow. It points out how important it is that you as the nurse make rounds with your doctors so you know what they're telling the patient. Doctors have a bad time giving bad news also. So you need to go in there, and when he says you had a myocardial infarction, you can say to the patient, "Do you know what that means?" Because let's face it, they get paid a whole lot more than you do, and they should be the ones to be given the bad news. You can then give the good news that it doesn't mean it's the end of their life. The usual cause of an infarction is hemorrhage into a plaque that causes a blockage. 90% of the time, that blockage is due to a plaque and blood clot formation or embolism formation. 5% of the time, 5 to 10% of the time, is due to a blockage that's due to spasm of your coronary arteries. It's usually from calcium influx. That's why if you have somebody who dies and they do a post, their coronary arteries may look, as they say, clean. It's probably due to a spasm, because that spasm will relax once somebody dies. Pathophysiologically, you will have 8 seconds, and then all the reserves of oxygen have been used, and the heart itself is cooler and cyanotic. After 60 seconds of hypoxia, you start to notice some EKG changes, so you notice that inverted T wave. In hypoxic states, you'll have a decrease in contractility because of the release of potassium, magnesium, and calcium into the vascular walls. You'll have an irregular heart rate and rhythm for the same reason, and you'll have an increase in your blood sugar because it's a stressful situation, and your blood sugar will go up because of the release of the norepinephrine. Now that blood sugar will increase within the first hour, and the stress response will be activated, causing a release of catecholamines, and that blood sugar will stay up for a while. With an infarction, you have the severe inflammatory response that is initiated, causing a fever. And within 24 hours of the heart attack, your leukocytes will infiltrate the necrotic area, releasing more catecholamines that increase the blood sugar again. And it will take about 2 weeks before insulin is mobilized from the pancreas. So for the first 2 weeks after an infarct, every time you check your patient's blood sugar, it will be elevated. Now, if they are not a diabetic, the elevation will probably only go to about 130, maybe 140. If they are diabetic, it can go up into the 250s. So that will make a difference. But remember, it's the inflammatory response that causes the fever, not an infection. Angiotensin II is released, causing peripheral vasoconstriction, fluid retention, and again more catecholamine release, causing spasm of that coronary artery. And then growth factor is released to start the ventricular remodeling. After 20 minutes of ischemia, you're going to have irreversible changes, and cardiac enzymes will be released into the bloodstream because you will have heart muscle death. And infarction is death of those myocardial cells. Now, there are about 3 types of MIs. You have a non-STEMI MI, which means that you do not have a non-ST segment elevated MI, and this is usually just of the subendocardial wall layer, and those patients tend to do fairly well. Or you can have a STEMI, which is ST segment elevation MI, and that involves about 2 layers of the myocardium, and those patients do fairly well. Or you can have a Q-wave MI, which is also a transmural wall MI, because it involves all 3 layers of that heart muscle, and those patients don't do quite as well. As the nurse, our goal is to stop our patient at the non-STMI level. We can do that if they come into the hospital in time. But we definitely want to prevent the transmural or the Q-wave MI. And this is showing the occlusion of the left anterior descending. That's this black area right there. So when somebody has a heart attack, your symptoms are pain. That's due to ischemia. Nausea, vomiting due to stimulation of the vomiting center by your pain fibers. Diaphoresis, cool, clammy skin due to vasoconstriction and stimulation of your sympathetic nervous system. Fever due to the inflammatory reaction. Hypotension because of the decrease in contractility of that heart muscle. Extra heart sounds due to a decrease in contractility and an increase in preload, or the amount of blood that returns to that heart. Extra heart sounds, like an S3 or an S4, due to a decrease in contractility and that increase in preload. Friction rub, due to enzyme release into the pericardial sac. And a friction rub sounds like 2 pieces of leather rubbing together. Increase in white blood cell and sedimentation rate due to the inflammatory reaction. Hyperglycemia due to the catecholamine release. The labs, you'll have an increase in your CKMB, your troponin level, your INT, your LDH1, and your AST. And they will elevate at different times, which will help you in staging when this infarct occurred. Your EKG changes, you'll show T-wave inversion because in about 97% of the time, T-waves are always upright. If you have a normal variant, you need to make sure the doctor knows that. And if it's inverted, it means ischemia. ST segment elevation means that you have some injury to that heart muscle, but you can still fix it. Q-wave means that you have myocardial cell death, and it will be with you forever. So when somebody has a Q-wave, it always indicates myocardial infarction at some time or another, because it never goes away. It's pathological if it's greater than 1 millimeter deep. ST segment elevation also has to be greater than 1 millimeter, and your T-wave, as I've already said, has to be upright to be normal, inverted to show ischemia. There are some complications to an infarct. You can have dysrhythmias, which are irregularities in your heart rate or rhythm. Dressler syndrome, which is a type of pericarditis, and we'll talk about that in a few minutes. Left ventricular failure. Congestive heart failure, we'll talk about that also. Papillary muscle dysfunction because of the trauma to that blood vessel wall. You may not have adequate valve function or cardiac arrest, which is something you definitely want to prevent. And this is showing the 3 eyes of an MI. The black area is infarct. Sorry, we jumped ahead. Infarct, injury, ischemia. This is all ischemia. Ischemia, T-wave inversion, ST segment elevation, injury, presence of a Q wave is infarction. This is over the area of the infarct. If you look on the opposite side of the reciprocal leads, you'll see that you have T-wave will be more peaked. Your ST segment will be depressed, and you'll have some coving in that ST segment and a taller R wave if you have an infarction. After somebody has a heart attack, the heart muscle doesn't function as well. So you have tachycardia, ventricular dilatation, and myocardial hypertrophy. That leads to a decrease in cardiac output, decreased renal perfusion. So you're going to have a decrease in urinary output, decrease in glomerular filtration, an increase in sodium retention because they're going to try and increase volume to compensate. That's going to increase your osmotic pressure, increasing your antidiuretic hormone again to increase volume. So you're going to have an increase in water absorption that again causes decompensation. This is why patients are oftentimes placed on ACE inhibitors to prevent that ventricular remodeling and beta blockers to decrease that cardiac output. Again, from the memory book showing the different types of symptoms that go along from a coronary occlusion or a heart attack. Okay, I already mentioned cardiac output is equal to heart rate times the stroke volume. Stroke volume is affected by your contractility, preload, and your afterload. So your heart rate, your stroke volume is the amount of blood that's ejected from the heart with each beat. So your contractility. Otto Frank and Ernst Starling back in 1914 discovered that as fibers stretch, contractility will increase to a point. When that point is overstretched, like a rubber band that's overstretched, the rubber band will break, but contractility of the heart muscle will be compromised. Contractility can be affected by anything that alters ventricular filling time, such as medications that increase the heart rate. As a result, they decrease filling time, or decrease the heart rate, which would increase filling time. Ectopic beats, irregular beats, are ones that do not necessarily occur when expected. If they're premature, they decrease filling time, and as such decrease stroke volume. The sympathetic nervous system increases the heart rate. The parasympathetic nervous system slows the heart rate, thus increasing stroke volume. Preload is your ventricular volume. It's actually the pressure that's generated in the left ventricle at the end of diastole. But if you think of it as ventricular volume, or the volume in the ventricle, anything that affects that volume of blood in the ventricle will affect preload. As fluids are increased, either orally or IV, by giving crystalloids or colloids, preload will increase. Medications that affect ventricular volume, such as diuretics, decrease preload. Medications that cause blood to pool in the extremities, such as nitrates, vasodilators, calcium channel blockers, or beta blockers, all decrease preload. Antiembolism hose, such as Job stockings, TED hose, anti-em hose, EPC cuffs, increase blood return to the heart and thus increase preload. Afterload, if you think of it as your systolic blood pressure, it's a lot easier. But it's actually resistance or impedance to ejection of blood from the left ventricle. But as your systolic blood pressure increases, it's harder to pump the blood out. Thus, afterload is increased. As the systolic blood decreases, it's easier to pump the blood out. Thus, afterload decreases. If blood viscosity is increased, if the blood gets thicker, harder to pump around, afterload will increase. So it's increased by blood viscosity and your peripheral vascular resistance, because peripheral vascular resistance increases with vasoconstriction as it's harder to pump the blood through the vessels. Thus, anything which vasoconstricts, such as vasopressors, epinephrine, dopamine, norepinephrine, will increase peripheral vascular resistance and afterload. Aortic impedance means that the aortic valve does not open sufficiently to eject blood. This tends to occur with diastolic hypertension and or aortic stenosis. So particularly the elderly are affected. Starling's law, just showing you a diagram that shows if you have normal contractility, cardiac output or stroke volume is okay. If you increase it a little bit, you can increase it, contractility. If you don't stretch it enough, that'll decrease it. But you just don't want to go overboard. Now your heart rate is affected by the autonomic nervous system. The sympathetic nervous system increases it, the parasympathetic decreases. There are medications that can affect it also. Atropine will block the sympathetic nervous system, allowing the parasympathetic to take over because it's anticholinergic. So that will allow the epinephrine and norepinephrine to take over, and so therefore that will increase the heart rate. Epinephrine and norepinephrine are your catecholamines. The calcium channel blockers, beta-adrenergic blockers, will decrease the heart rate. The basal metabolic rate is affected by changes in your temperature. Increased temperature or increase in thyroid hormone will increase the heart rate. A decrease in temperature or a decrease in your thyroid hormone will decrease the output. Thyrotoxicosis is when you have too much thyroid hormone, if you remember. Pregnancy or exercise will increase your cardiac output. The renin-angiotensin-aldosterone system can cause vasoconstriction, thereby increasing afterload and increasing fluid retention in the kidney and increasing preload. Usually nurses are interested only in decreased cardiac output, but there are several instances of increased cardiac output that are a concern. Whenever there's a decrease in the systemic vascular resistance, which occurs with sepsis or an increase in oxygen demand, as in thyrotoxicosis, pregnancy, or exercise, your cardiac output will increase, and that can be a concern. This is a diagram showing cardiac output caused by heart rate and stroke volume, and the different things that affect heart rate and the different things that affect stroke volume. And we just talked about those rather extensively. This again is looking at preload and afterload. Preload is looking at the fluid going back to the ventricles. Afterload, trying to pump that blood out. And again, this is from the memory book. I think this is where I'm going to stop for part 2. We may actually end up with 5 parts to this lecture, but this will be the end of part 2.